Consumer Protections, Troy Ruff. Troy, are you on? Oh, Troy is right here. Troy is going. I don't know why I always think you're not in the room. I apologize.
It's okay, Madam Chair.
After we just spoke. Okay, thank you, Troy. And if you want to kick it off, that would be fantastic.
Good morning, Madam Chair, and thank you for giving me the time to speak today. My name is Troy Ruff. I'm the Director of Consumer Protection Department, Drug Control Division. Today, I want to go over a few items with the working group. First, for those who do not know, the Drug Control Division works to protect the health and safety of the Connecticut residents by regulating all persons and firms involved in distribution of all drugs, medical devices, and cosmetics in Connecticut. The division oversees Connecticut licensing for pharmacies, pharmacists, controlled substance providers, and laboratories, pharmacy technicians, manufacturers, and wholesalers of drugs, cosmetics, and medical devices. The Drug Control Division is also responsible for the prescription monitoring program. Our focus is education, compliance, and the oversight of pharmacy and prescribing practices. Today, I want to speak to you about the pharmacists who we license. Pharmacists are medication experts who play a critical role in ensuring patients receive the right medications at right doses and the right way. They bridge the gap between prescribers and patients, helping prevent medication errors, adverse interactions, and misuse. Beyond dispensing medications, pharmacists provide clinical services like immunizations, health screenings, and chronic disease management, especially for conditions with diabetes, hypertension, and asthma. They often catch potential issues before they become serious, improving outcome and reducing hospitalization. Pharmacists are also one of the most accessible healthcare professionals in many communities, especially underserved areas. They are the first and sometimes only point of contact for health advice. Their accessibility helps reduce the burden on emergency rooms and primary care providers. In short, pharmacists are not just dispensers. They are trusted healthcare providers who ensure safe, effective, and personalized medication use, making them indispensable to the healthcare system. In our state, we currently have a total of 6,617 active registered pharmacists. We have 4,378 of those pharmacists who are vaccination trained. We have over 2,000 pharmacists who can prescribe naloxone. We have 770 active pharmacy interns, and then we have over 8,000 pharmacy technicians who assist the pharmacists in their daily activities. Training for the pharmacist starts with a 6-year program where the pharmacist receives a Doctor of Pharmacy degree, also known as a PharmD. Pharmacists also have the options of board certifications or participate in a residency program for specialization. Over the last 15 plus years, the role of pharmacists has grown where they're able to administer vaccinations, including flu, COVID, and other CDC recommended vaccines. They participate in collaborative practice agreements with physicians to manage drug therapy under written protocols, performing HIV-related testing and prescribe and dispense HIV prophylaxis, conducting flu testing, prescribing and educating patients on naloxone, prescribing hormonal contraceptives and other FDA-approved products. Lastly, our laws for pharmacists and pharmacies do not address reimbursement. I would have to defer to our partners from DSS, CID, Centers of Medicare and Medicaid Services who may be able to speak on reimbursement. I know others in this committee have already spoken to other states that allow reimbursement of pharmacists and pharmacy services, and there are other states that are passing laws giving access to pharmacists provided patient care services. For example, Maryland, North Dakota. I think Ed spoke a little bit about a few of those states as well. So that's basically the information I kind of wanted to go over today. And if you have any questions.
Yeah, we'll open it up to questions. I had a couple just to kick things off. So pharmacists, you said there's a 6-year program, and then there's board certification. What about continuing ed?
Yep. So there is continuing education that they must have every year, 15 CEUs, continuing education units, with 5 being live, 1 being law. So
Okay.
that's done. And there's also a requirement if they are immunization certified that they must take a CE for immunization every year.
Okay.
And they also have to be, for immunization, they also have to be CPR certified as well. So.
And then what about carrying any type of insurance like liability and E&O and stuff
Okay.
like that?
So that's not required in our law, but there are pharmacists that carry their own liability insurance, and then obviously the companies that they work for or organizations that they work for will will or can provide it to them.
Okay. Any other questions? Sue Halpin.
Hi, thank you very much for your remarks. They're very helpful to put what we're talking about in context. Would love to have them in writing if you're able to share them at a future time. Just some of the statistics you named were really interesting. Um, for if you don't know who I am, I'm Susan Help, and I'm here sitting at the as the executive director of the Connecticut Association of Health Plans, so the health insurers. And health insurers, there are many services in the state that are not mandated to be reimbursed by insurers that are reimbursed by insurers. So I think one of the things I've learned in this conversation is either the connection or perhaps disconnection between the licensure categories at DCP and those at DPH. Is there any, for instance, is a pharmacist considered a healthcare provider under the Department of Public Health statutes, to your knowledge?
I'd have to refer to Department of Public Health on
Okay.
it. I know in our laws we discuss that piece.
Okay. So they're licensed through you. I know you're the governing body for all things pharmacy. I understand that. I also know there's a list in statute under the Department of Public Health that lists all licensed providers. And I haven't had a chance to go back and look, but if I'm recalling correctly, I don't think, and maybe one of the folks sitting around the table would know better than I do, whether pharmacists are listed under the definition of healthcare provider for purposes of public health statutes.
So, Julian Karuni, I'm a pharmacist by training. I also work with Walgreens. Pharmacists are currently not listed as a healthcare provider under that statute.
Okay.
And because we fall under the Department of Consumer Protection versus DPH, that is a gap that we need to close.
Okay. That's very helpful. Thank you very much.
Any other questions for Troy? So Troy, can you walk through the regulatory process for pharmacists? We're talking about DSS and DPH. It falls under the Department of Consumer Protection because of dispensing drugs, correct?
That's correct.
Okay. And is there I'm just trying to think of my, working with the insurance department. Is there a consumer affairs division? Are there, tracking complaints and things like that DCP does?
So we have somebody on staff Monday through Friday, 8:30 to 5, a drug control agent that answers the phone systems for us. And there are some consumer complaints that come in, cases come in, other items for the drug control division.
Anyone else? Okay, great. And we did invite DPH to present today. They will be coming to a future meeting. They said they would like some more time. So we could do the same kind of thing where they come in and chat with us and we can ask some questions. All right, so we will move to Dr. Travis Wolf from PharmD, Director of CPESN Medical Billing Supports within the Community Pharmacy Enhanced Services Network. Thank you so much for coming today, Dr. Wolf, and we'll pass it over to you. And I preface Dr. Wolf is that our working group is really laid back and he's going to present, and then we can all just kind of jump in and ask questions.
Great. Thanks so much for having me today. I'm excited to be here. So a little bit of my background. So I previously was a pharmacy owner, and I put a lot of clinical programs into my pharmacy. We found unique ways to collaborate with physicians in order to be able to make those programs sustainable for patients and to track our outcomes. We did it way before it was cool. So that was 15, 20 years ago. And because of that, we were recruited by several national organizations to start teaching others how to do that. So more recently, I won't bore you with my entire history, but I've got several trainings and certifications outside of pharmacy as well to figure out how we can work with other healthcare professions. A lot of those are psychology and leadership based. And more recently, right after COVID happened, I was contacted by the CDC and they saw the impact that a pharmacist could have because of COVID vaccines. And they saw, because of that access to care, how we could really provide such a public health initiative to those because of that access to care. So they asked me to come on board with them as a contractor. And there were many states that had passed pharmacist specific legislation, very different forms. It could be statutes, it could be bills, it could be lots of different things. It could be work groups that pushed into maybe like a Medicaid rule they were trying out, lots of different forms and fashions. And my job for them when those laws got passed was to work with the legislative committees and help communicate what they designed through to the actual pharmacist to make sure they were doing it right, to make sure they were performing the service correctly, documenting it, billing it correctly, as well as work with the payers directly. So we would come and say, hey, the Connecticut Insurance and Real Estate Work Group, they did put together this legislation. Here was the intent. It went through, and there's a bill. Here's what we're trying to accomplish. And then now, as a payer, you get to choose how you want that to be billed to you. How do you want to credential a pharmacist? How do you want them to document the care they're giving? And how can we make that work synergistically with the other healthcare providers? So I would literally get pulled into a state, and then they would cold call me in, and I would work directly with pharmacists, and I would call them, and they would think it was just too good to be true. I would say, hey, Ed, do you like diabetes? And Ed would say, sure, I don't mind diabetes. And I would say, what if your health department could refer 20 patients to you a week to take care of their diabetes? Would you be willing to do that and get paid this many dollars? And I have grant money that will pay you when you medical bill it correctly. But you got to learn, we got to get it up and going in 6 months because the legislators need the data to see the outcomes so that they can do a budget because of this new bill they're trying to push through. So I did that for a handful of years right after 2020 hit, and I still do that, not as heavy because we've got a lot of the states caught up. And then about 2.5 years ago, CPESN, which stands for the Community Pharmacy Enhanced Services Network, they reached out and asked me to come do exactly what I'd been doing for the CDC for them. And it's been a lot of fun, but I wanted to share some of the highlights with you today as you guys are kind of in the stages of trying to figure out what this looks like in Connecticut. And I'd love to take any questions. The whole thing to think about is we get stuck in scope of practice and we get stuck in statutes. However, as a state, you get to design what that needs to look like. And I'm not sure the question earlier that was asked about pharmacists being on that qualified provider list, I'm not sure if that was state specific or federal, but what I would tell you is we all go by what's called an FQHC, which is a federally qualified healthcare provider. Pharmacists are not on that list. So that comes from CMS statutes. However, we've got 38 states now that have decided to give some form or fashion of provider type opportunity to pharmacists, and they do it within their state rules. And there are many different ways you can do it. And when you do that, it can really make a big impact on your state's patients and their health because you can, however you set it up, you can make it so that all commercial payers can provide that service. And you can make it so that your Medicaid can provide that service. And I'm going to talk through some states who have done that. Medicaid is usually 80% federal dollars and 20% state, just roughly depending on the state. You can't use a federal dollar to pay a pharmacist, but you can use a federal dollar to pay a pharmacy. So in medical billing, when you send the claim through, there can be a referring provider and a rendering provider. So we have lots of states that have said we need to cost control our Medicaid dollars and we need better outcomes and we need access to care. And it's for a number of disease states. And what they've done is they set it up so that the pharmacist who's performing the service is the referring provider. But they've made it so that the pharmacy is the rendering provider. And you can pay a pharmacy with federal dollars all day long. It happens right now for the drugs that get dispensed. Furthermore, Medicare, CMS, I work directly with them too in my CDC role. They have lots of modalities where they've defined the pharmacist to be able to provide these types of care situations. It's just the payment is a lot of smoke and mirrors because they also could not pay a pharmacist directly. But we don't have time to get to that today, and you guys are not using Medicare dollars. You're probably going to be using Medicaid and commercial dollars. Maybe another day we can talk through that. But there are several different ways they can do that. So I'm going to send a request to share my screen if I could. I got a couple different slides I'd like to show.
Yeah, that would be great. And does anyone have their volume on here? Because I'm hearing an echo that is just a little bit annoying. And Dr. Wolf, if you could turn your mic on and off again and just try to work through this weird feedback issue we're getting. And then you can continue, please.
Okay, is that any better?
No, yeah, your audio is just a little bit weird, but we'll do our best to follow along.
Okay. Can you all see my screen okay?
Yes.
Okay, great. So I'm going to give you a little history here so you guys can know what's possible, because sometimes we get stuck in our own states and we can't always know what's possible out there. So on my CDC role, we track a year behind. So last year, we looked at what was done in 2023 and implemented in 2024. And then this year, we look at 2024 that we're implementing in 2025. So in 2023, we had 183 bills across the 50 states. We also work with the Virgin Islands and Puerto Rico because they can use Medicare dollars, being a territory. And most of them were around the pharmacist scope of practice, the payment for pharmacist provided patient care services, as well as the designation of pharmacists as providers. 55 bills in 32 states were signed into law. Most of those are going to be around vaccine authority. I heard you guys mention earlier, but HIV, PrEP, and PEP prescribing authority, opioid antagonist prescribing, medication therapy management, point of care testing, contraceptive prescribing, collaborative practices, and then many are actually allowing this preventive and evaluation management. There are many different ways you can do this. What I would tell you is some of these have come out of the basis because there's a need for patient care, not because pharmacists have been super trained on it. And so it's quite funny to me that we would give pharmacists the ability to prescribe HIV, PrEP, and PEP, but some states still won't let them choose to give a patient a flu shot without a prescription or a standing order or a collaborative practice agreement. It's just things to think about because we get pigeonholed sometimes and we think we really need this HIV problem to be accessible for a solution. So we're going to have pharmacists do that. Contraceptive prescribing is another big one that we see is a lot of pharmacists say, I didn't go to pharmacy school to prescribe birth control, but they're given that opportunity because there's a need for it. There's access to care. And then the legislators sit and watch and no one gets paid or bills for those. And they think pharmacists aren't capable, but really they're just not doing it because it's not their passion. So I think that's something to think about when you're thinking through what you might provide as an opportunity in Connecticut. In 2024, we had 165 bills introduced in 41 states. Again, kind of the same thing as far as scope of practice and designation as providers. And we had 45 of those in 31 different states signed into law. So when you think about that, it's not always, you can see the numbers are not showing that we're just adding new states all the time. Sometimes states have started with a bill that either went well and they expanded it, or didn't go well and they really changed it to try to figure out what they could do in order to make it easier. So some important considerations for you to think through whenever you're thinking about how to set this up as your work group and what recommendations to give in Connecticut. There are three big things in thinking about your legislation. I'm going to give you some examples in different states of things I've seen go well. Of course, we all get stuck in scope of practice. A new term that I've been using for the last couple of years and trying to coin with everyone else to use is scope of license. So the scope of practice is how the pharmacist is trained. And there's a standard across all the different states for that. When you go get a doctorate of pharmacy and you earn that PharmD, there's a standard in the curriculum and as to how that pharmacy school or college of pharmacy was accredited. And so we're all trained to do similar, if not the same things. But the scope of license is what our state says we're allowed to do in that state. And I'm going to give you some very good examples as to how that can be different for the exact same patient and disease state and pharmacist, depending on what state they're standing in whenever the evaluation happens. I also want to talk about insurance code a little bit. We've had one state use that very effectively, and it has made things so much easier for everyone involved. And then once you get past those three kind of big things, I wanted you to look at more on a granular level with me what it looks like to give comprehensive scope versus limited scope, and just some ideas you could consider as you're moving your work group forward. So Wisconsin is one I wanted to talk through. So they have scope of practice, and they designed this, pretty well. They're one of the newer ones that just launched in July of last year, of 2024, and they really have done a good job stewarding the types of services and the outcomes that they're getting. And so they basically put it out there that pharmacists must be reimbursed for services delivered within the scope of practice. So the scope is defined by their administrative code FAR 7. And basically, it says that it does include the activities associated with dispensing medications, but it also includes counseling patients, because a lot of the questions that we get are the same questions that a doctor might get in their office, and taking the extra time to go and have those conversations, making sure the medication is taken correctly, make sure we're avoiding side effects, duplicate therapies, inappropriate therapy, those types of things. Providing immunizations, conducting health screenings is another big one we have in there. Theirs actually had this, and not all states do, but they also had the CLIA waived lab test in there too. That's going to be things like swabbing a nose or a throat for flu or strep or COVID. We also have point of care testing for diabetes and cholesterol. Those get a little more complex, but the black and white flu test and COVID test and strep test, those get a little bit easier. And then, so what they did that was new that went into effect last July, they put in Wisconsin Act 98, which was more around Medicaid dollars because they needed to control the outcomes and the dollars being spent there. And the Medicaid said, we will allow pharmacists to register as providers. We're going to pay the pharmacy as the rendering provider. And we're going to allow that for chronic disease state management, immunizations, and patient education within their scope. And so the scope, of course, was already defined. So they had, half of their work kind of done for them. Sometimes the scope is limited based on how the state has it designed. So you got to watch out for that as well. But it basically gave the opportunity for, 1.4 million Medicaid, beneficiaries to benefit from those services. And again, the referring provider, they're credentialing the pharmacist who's providing that service, but they're paying the pharmacy. And they didn't change the scope at all. They just said, we're going to allow Medicaid dollars to be spent on this. And so that is one. This one is probably one of the best ones I've seen. So Texas, they did a two-pronged approach. They did one bill that instead of adding different things, they just said anything that a physician or a nurse practitioner or a physician assistant is paid for that is inside the scope of a pharmacist, we're also going to pay a pharmacist for. So they didn't give them anything extra beyond what they were doing. So they can't prescribe. And honestly, the most successful states I've seen have basically reimbursed pharmacists for what they're already doing to make a sustainable care model for patients. It's saved big state dollars doing that. So it's not necessarily getting into the scope of other providers and expanding it. It's not about giving them prescriptive authority or diagnostic ability. It's things they're already doing to help manage these disease states. What's unique about Texas is they had another bill they passed that would formally recognize pharmacists in the insurance code. And that has helped more than anything. And every state that I talk to is trying to get that done now. Because even when the legislators want something, and even when the pharmacists are willing to do it, and even when the patients can benefit, the payers don't always have to follow all those rules if it's not in the insurance code. You guys were mentioning, which board is regulating pharmacists and who's under this, who's under that. And we saw it right here in front of us today where I would defer to that board because they're the expert and that's in their umbrella. So the same thing happens here. The payer says, well, I'm not governed by anything that has to do with the pharmacy board or the medical board. I'm governed by the insurance code and I have to go under what they say. So by putting both of these rules in there, it helped everyone be on the same page to say not only is this being said and this needs to be done on the healthcare side, but now those that regulate those paying for that insurance, they also have to do this. So this has really been helpful because in addition to the Medicaid, which is state-controlled dollars a lot of times, the commercial insurance companies are having to do this. So now the Texas pharmacists, they're able to take care of patients and get paid for those services for anyone that's not on Medicare. If they're on Medicare, it's still a federally qualified payer, and they're not qualifying for that. The third state I was going to give you an example of, and then I'll kind of show you how this works in the intermixings, was Minnesota. So they have a statute that's 19 years old. They've been doing this longer than anybody. They put it under medication therapy management services. They have a great payment model. It's very well outlined, and you follow this algorithm and you use the lowest possible box, so which would be the highest box on the chart. So they can have one medication and no drug therapy problems, or they could have two medications and one drug therapy problem. But I want you to look at number three. Number three is 3 to 5 medications and at least 2 drug therapy problems. So if they had 4 medications, but only 1 drug therapy problem was identified, then they would bill on a level 2, not a level 3. But it's really well defined. And these codes are one of those that was designed by Medicare for federal dollars to pay for a pharmacist to perform it. What happened is we had PBMs and other entities get involved so that they solidified all the Medicare MTM where this was designed to be done to go through one vendor, who now the vendor is in control of who gets to do those services, what the payment might look like, and if that pharmacist who has the relationship with that patient even gets the opportunity for that. But I think it's ironic that these codes are Medicare codes. These codes were developed for federal dollars, and yet the pharmacist taking care of that patient doesn't have access to use them. So Minnesota saw that early on, and they gave that ability back in their Medicaids. And the Medicaid, it goes across their straight Medicaid, and they also have 9 MCOs. And so the pharmacist can credential and they can bill these codes across there. And they did that 19 years ago. Starting this next year, they're going to open up full evaluation and management codes as well, but they have a ton of data because they've been doing medication therapy management for a long time. So let's talk more about the scope of practice and the scope of license. So if you notice, green comes from the combination of blue and yellow, okay? So blue is scope of practice. That's how the pharmacist was trained, and we're all trained a similar way across all 50 states. The scope of license is what the state of Connecticut says we can do, okay? And you put those two together and we get the green area in the overlap. That is what we can bill for, how we can bill for it, and what needs to be done to document those services. So the example I want to give you is a vaccine consult. So this would be someone comes into the pharmacy for a flu shot. So even if you're able to give vaccines and bill for that vaccine on the medical side, a physician can bill to go through a vaccine gap analysis, and they can say, it's great that you want a flu shot. Let me check to see if you're due for a pneumonia shot or a shingles vaccine or an RSV vaccine. Furthermore, if you didn't know, the RSV and the shingles vaccine, it's only reimbursable on the pharmacy side for Medicare patients. Physicians can't even get it or bill for it. Yet pharmacists are not equipped to do this consult and get paid for it. They're doing it all the time for free, but a lot of them skip it because they don't get paid for it and they don't have the time for it. So on a vaccine consult patient, so someone that comes in for a flu shot, and you're going to see if they also need shingles or pneumonia, tetanus, those types of things. In Texas, with a Texas bill, I can use those preventive medicine codes just like a physician would, and I can bill that out in the E&M profile. E&M stands for Evaluation and Management, and it's the same code set because the code just says how long I spent with the patient and the level of medical decision making inside my scope. So those E&M codes are used by nurse specialists who are still just a registered nurse. Those are used by nurse practitioners who are actually a prescriber provider, physician's assistants, MDs, DOs. So the same kind of thought concept of pharmacists can do things inside their scope, and then they can bill out using those same codes. It makes the tracking a lot easier for the dollars being spent by what kind of profession. Okay, but in Minnesota, until this new law goes into effect next year, I just told you about, now we have blue and red that makes purple. So the same patient walks in for a flu shot in a Minnesota pharmacy. The Minnesota statute says vaccines are specifically under medication therapy management. So now they're going to use medication therapy management code, and their documentation is going to look totally different. Either way, we can still give the pharmacist a provider type relationship with the patient. They can bill for the time they spent with the patient, and the patient gets access to care in preventive health measures. The last few things I want to share with you, then I'll open up for questions. So the comprehensive scope versus the limited scope. I've seen this done both ways in different states, and they both work, but it's not without repercussions that you don't always know about. So vaccines, it is so interesting to me that all 50 states have not given pharmacists the ability to bill for vaccines and to bill for that consult where we're doing the extra time to see what other vaccines they need. That's interesting to me because during the pandemic, when the emergency use authorization came out and pharmacists could actually prescribe their own COVID vaccines, we were able to show that 80% of all COVID vaccines were administered by community pharmacists. Yet the minute that emergency use authorization went away, we lost the ability to do a lot of things. And so that would be a no-brainer to me in a comprehensive scope, is that pharmacists could go ahead and bill for their vaccines on the medical side and not just on the pharmacy side, and that they could bill for that office visit. We're actually doing a consult because pharmacists are not throwing flu shots like darts. They're going outside a workflow and they're sitting down in an office type setting just like you would do in a doctor's office. We also see comprehensive scope being things they're already doing, the right drug at the right dose. There's lots of work that goes in besides putting pills in a bottle. There's lots of time spent that if they were a physician, it would be a peer-to-peer consult or a physician-to-peer consult, because a pharmacist calls a physician and says, hey, I got this prescription and you send it for this dose. This other doctor they're seeing is a kidney doctor, and they have dosed that medication to be appropriate for low kidney function. Did you know that they had low kidney function? And they're saying, no, I didn't know that. I need to redose my drug too. Great, that's why I'm calling. So that happens all the time. The other thing that I see happen a lot is pharmacists are not only an expert in the drugs and the disease states and how those are used, but a big portion of pharmacist education is the delivery device. So there are about 8 different ways that a tablet can release medication in your stomach, for example. And based on what that tablet delivery is, some pills are taken once a day, twice a day, 4 times a day. And often a physician will write a prescription that will be under or overdosed because they sent the wrong tablet formulation in the electronic prescription. A couple of really common ones is a blood pressure and heart drug called metoprolol. It's been around for years. Tons of people are on it. It was even on the Walmart $4 list for years. And I can't tell you how many times I've called as a pharmacist to say, hey, you sent that metoprolol tartrate once a day. Did you mean to send that twice a day? Or did you want the metoprolol succinate once a day? Again, that's care management and time. Or I could just put it in a bottle for what they prescribe, which is what your non-pharmacist touch point pharmacies are going to do if you get into these big mail orders and stuff where the pharmacist is not getting compensated for their time. Another one is called bupropion. We use that for depression, anxiety, tobacco cessation. There is an SR version that needs to be prescribed twice a day, and there's an XL version that needs to be prescribed once a day. That's another one. There's lots of drugs like this I could talk about, but these are things pharmacists are doing that I feel like if we don't compensate them for, it's going to go away. This was a great study as well. It's an older study actually, but it shows exactly what we see the most recommendations come from. So just clarifying dose, frequency, dosage form, that's a billable event in the states that I showed you. It would be billed with different codes in all 3 states. So Wisconsin and Texas and Minnesota would all bill it differently because that's how their state work groups designed it in their legislature, but they get paid for that time. And because they get paid, their documentation is 10 times better than it ever would be if they're just making a phone call and using a sticky note. Removing drugs from a medication list, that also saves money on especially your Medicaids for following formulary protocols. Adding an indication for a drug, why are we on this drug if we can't figure out why they're taking it? Adding a drug to a medication list. We typically see pharmacists being a hub where the patient has at least 3 different physicians or prescribers and 1 pharmacy. And so we often see that each doctor does not know the drugs that they're taking by different doctors. Modifying the regimen, discontinuing retail prescriptions. So these are the big things. And I think whenever we start talking about pharmacist provider laws, the other professions' alarm bells start going off and we get in the threat mode. And instead of thinking about patient care, we start thinking about our paycheck. But pharmacists are not after providers' paychecks. Pharmacists are trying to build a sustainable model to take care of their patients. So I think it's important when you go into this new frontier in Connecticut, you got to think about how to send that message that it's not scope creep. It's actually more accountability for the pharmacist, because if they're getting paid for that encounter, their documentation of what they did is going to have to be that much better, because they got to have continuity of care now where they can refer that in out of their scope and what they did into the doctor from like an EHR setting. And if they get audited for that payment, they got to be able to show what they did in a reasonable way. We see sustainability, as you guys know. I haven't heard a bunch about Connecticut, but I know in lots of other states, it's not just independent pharmacies closing. We're in my state, we're seeing CVS's and Walgreens closing because they do not have the sustainability in the dispensing model. So we got to find another way to keep these pharmacists around to be able to perform these services for our patients. And if we don't start doing that, the few cents and dollars that are being put out there for dispensing, it's not going to cut it. We're going to be in a big trouble as a nation for sure. I also see a lot of synergy possible for other healthcare providers, because if the pharmacist is able to focus on this and have the autonomy to make these decisions, now your physicians and your nurse practitioners and your physician assistants can actually focus on what's important, because they're not arguing over what's on the formulary. They can actually take care of the bigger things patients came in for anyway. The last thing I'll talk about is limited scope. So some states don't do the comprehensive thing because of that fear of scope creep. So they give a very specific thing. Point of care testing can be used very effectively because it's black and white. Pharmacists actually get at least twice, if not 3.5 times, the amount of education as physicians do on drug therapy management for chronic disease states. What pharmacists don't get is diagnosis training. So anything that's got a definitive diagnosis, such as a point of care test for flu, strep, COVID, a urine test, these are even available over the counter now. I mean, you probably have seen them. You can go buy the test, you can swab yourself and get diagnosis right there. So if it's available over the counter, I don't know why we wouldn't give pharmacists the ability to at least participate in helping them navigate what to do once they get a positive test. Blood pressure, there's tons of research out there on blood pressure. You wouldn't even need a CLIA waiver. And how many pharmacies have blood pressure cuffs? It's actually a liability, I feel like, to take someone's blood pressure and not be able to do anything about it. We don't need the ability to prescribe new drugs. I think that is appropriate in the physician's hands. But if they're on a low dose of a drug, it would be totally appropriate to be able to ask their personal doctor if you could go up to the next dose of the same drug they're already on, because you've taken 2 blood pressure readings that are out of range. It's kind of a no-brainer. There is also another category of things where they've just shown the benefit is greater than the risk. So this would be naloxone prescribing. Lots of states have done this. I know New Jersey has been really successful with this, and they're really close to you guys. A pharmacist can prescribe the naloxone out to patients who have opioid prescriptions. You can also prescribe it to family members who are concerned about family members that might be at risk in their household of opioids. Tobacco cessation. It would not be the end of the world for a pharmacist to be able to prescribe nicotine patches or nicotine gum. The difference is if they can prescribe it, the insurance can pay for it. Right now, patients can't afford tobacco cessation because they're paying cash for it over the counter. But if the pharmacist could have that ability, then they could bill for the office visit for the tobacco cessation. There are 2 specific codes based on how much time you spend with the patient. Immunizations I talked to as well. We're definitely qualified to do that, but we need the authority from the states. Almost every state board of pharmacy I've talked to has said that if someone has an albuterol inhaler prescription and they've filled it somewhat regularly, if they're out of refills, here's the example that I've been given by several different states. So I don't know if the state boards talk to each other, but they say if that is a child going out of town for a Boy Scout camp out and they're out of refills, you should loan them an albuterol inhaler and contact their doctor for a refill, and hopefully you get that back by Monday. This is a common practice to loan these things without refills if it's a regular patient who regularly fills it. Wouldn't it be even safer if we let the pharmacist prescribe the albuterol inhaler for someone that already had a prescription for it, if they had that refill, because now there's documentation of it and the patient doesn't have to pay out of pocket for it? Same thing with epinephrine. Why would we want to limit those who have allergic reactions and allergies when they're very expensive products that a patient's not going to be able to afford even if we put it over the counter, we're going to have to be able to bill insurance for it. So these are just some things that I've seen in limited scope. And I think if we reimburse the encounter, then that's how we get this sustainability as we're in this hard thing. This is my last slide here. You guys are in control, so you basically get the ability to have what I call the triangular benefits. So on one side of the triangle, you've got patients, the most important thing, right? We got to take care of our patient. The other side, you've got the pharmacist who is trained and willing to do some of these things. And the other side is the payer and the state legislature. We got to be responsible for the lives we've been trusted with. We got to be responsible for the tax dollars we've been trusted with to take care of those lives. And nothing is outside of the question of what if. And so these are specific things that I've set with committees like yours that we've designed where there's been an issue. Vaccine gap analysis, we talked about that a little bit, but Missouri did a phenomenal job with vaccine hesitancy codes. They were actually G codes by Medicare. And people would come in and they would offer them a COVID vaccine. And then they would say, I'm just not sure. And so they would talk to them about, the risk and the benefits, and the patient would think about it. And if they came back and got a vaccine within so many days, they were able to bill a code out because of that counseling and that time they spent with the patient. We had some payers that were needing A1C test just for their HEDIS measures. Pharmacist wasn't prescribing diabetes meds. They weren't doing anything but sticking someone's finger and reporting that number to the doctor. That's all they're doing. Blood pressure monitoring, contraceptives, HIV, PEP, and PrEP. Contraceptives, you might be wondering what that's about. We're in an OB desert in the United States right now, and it's only going to get worse. And we're ending up with a lot of NICU babies that are costing Medicaid a lot of dollars because those are $1 million babies, and we have one in the NICU. And we have been able to curtail a lot of that with access to contraceptives. I'm talking to one state right now about syphilis screening. Syphilis is on the rise, and the treatment is only in health departments, but the population that needs that are going into pharmacies. They're not going to the health department. Lots of opportunity for education, heart failure, weight loss, diabetes. These are things that we're already doing. So I think giving the ability for pharmacists to be reimbursed for it will help make that a more sustainable model. So sorry, I went a little bit long there, but I kind of get excited about it. So any questions at all you guys have?
Yeah, let's open it up to questions. There was a lot in there. This was fantastic. Thank you for this presentation. Do we have any hands up? Anyone online?
You gotta send us the.
Ed?
Hi, thanks, Dr. Wolf. That was very informative to the group, and I'm sure everybody appreciated it. Just a comment and then a question. So obviously, you can see there's a lot of opportunity to engage pharmacists to improve patient health, and a lot of Dr. Wolf's this presentation went through all that. So that was great. My question to Dr. Wolf would be, so we're starting here. We have our work group here in Connecticut. Right now, we have no laws around pharmacists doing direct medical billing. And you mentioned the two phases in Texas, the two different laws. And one was talking about scope of practice and scope of license, where the other one was recognizing pharmacists as providers under the Texas Insurance Code. So translating that into Connecticut, what would you say what would you advise that our path be, for Connecticut and this committee? What recommendations would you give us? Considering those two things, how would you move forward here?
Yeah, that's a great question. So there's two steps that I would take if I were you. Number one, I would look to see where and how the scope of practice of a pharmacist is defined in Connecticut. Okay. If that scope is already defined to include some of the things that you feel like are billable events, such as patient counseling, if immunizations are in there, resolving drug therapy problems, every state will have their own definition of the scope of practice. But I would start there. And if it has everything that you think is needed in there, that you think is beyond putting pills in a bottle, then your second step would just be trying to formulate a bill or a Medicaid rule. And what that bill would say is anything that a physician gets paid for by a payer that is inside the scope of practice of a pharmacist, they must also pay the pharmacist. That's not creating anything new. That's not pushing into scope creep. It's saying we're using this scope of practice. And if the doctor called another doctor and said, "Did you mean to prescribe this dose of medication?" That's a billable event. If the doctor calls the patient at home and brings them in for an office visit to get a vaccine, that's a billable event. These are things that pharmacies do every single day. So I would start with that. If you pull your scope of practice on step one and you feel like it's not well defined and it's actually limiting, then you got to start there. And you got to figure out, how can we define the scope of practice? So not so that it expands the scope, but so that it more clearly defines what's actually being done in the pharmacy.
Yeah, which is one of the reasons why we want a DPH here. So to understand that a little bit further, but we can have them at a future meeting. Stephen Muskers?
Thank you very much. I guess I'm having conflict here in the discussion. I certainly don't object to pharmacists being compensated for the scope of service. Where I have a problem is I broaden the scope of service or reimbursable service to the pharmacies and put the payment of service on par with the delivery of the service with doctors. I'm more than likely to increase the demand on the insurance companies and therefore increase the cost of medical service. I know outcomes are improving, but I would be much more, this might be just me personally, and I'm only one voice on the insurance committee, but if I'm creating a competitive environment where I'm improving the delivery of service and potentially lowering the cost, you have better buy-in. For me, I have sat through what, 7 years of listening to improving outcomes someday in the future with spiraling costs. So I think a competitive environment where I'm compensating pharmacists for things they're not compensated for, but I'm transferring, and that's the question, and the battle will be on the scope of service. I'm transferring some of the obligations to pharmacists versus doctors, and the rate of compensation is different. That's where I see my personal interest, and I want your thoughts on that. I'm concerned that I go mission creep, and it's not an attack on pharmacists, that I'm just going to end up with spiraling premiums.
Yeah, it's a great question. So when we launch new legislation, a big piece of what we do is setting up the tracking of those dollars saved and the preventive measures that happen.
Right.
And so there are dollars being spent on those codes to pharmacists, absolutely. However, we set it up so that the ability to prevent poor outcomes is actually saving overall dollars. One of those really good examples and I use Medicare a lot because they're the standard, even though they don't give pharmacists the ability to bill, right? But
Right.
When someone discharges from the hospital on Medicare, a complicated patient is supposed to be scheduled at the doctor's office, the primary care, within 7 days, and a non-complicated patient has to be scheduled within 14 days. For either one of those two things to be billable by the doctor, not only for them to get paid for the visit, but also to get their quality points of Medicare, a medication reconciliation phone call has to occur within 48 hours of their discharge. So a lot of physicians don't get that done because they don't even know they're out of the hospital in 48 hours. They don't even get the post-discharge paperwork until it's almost too late. Where does the patient go when they leave the hospital? They go to the pharmacy to pick up their new prescriptions.
Right.
What does the pharmacist do? They say, here's the list of medications you were on before going to the hospital. Here's the list of what you got new in the hospital. And here's the things the doctor wants you to stop taking. We have found hundreds of thousands of adverse drug events when that did not occur. And it happens. I personally had a patient die from it. Had a patient who had a history of bleed strokes, and they were well managed on a blood thinner. for 17 years. They had a clot stroke, went to the hospital, they were treated, survived. They were discharged. They were told at bedside by the discharging nurse to continue all home meds, and they were prescribed a new blood thinner. So the patient filled the new blood thinner, had the old blood thinner at home, and they took them both. And 5 days later, they had a bleed stroke and they died. So, had that been a billable event for the pharmacist, they would have done a better job on that med rec because it'd be required. But they can't even report what they do for that patient anywhere. And one other thing I would just mention, as far as the health insurance and the payment and the dollars, because you don't have that provider ability for pharmacists, a lot of the things they're doing are not reportable or trackable. Whereas a physician, anytime another physician touches a patient, the insurance and the other physicians are getting follow-up referral cares because insurance can see the codes. They can see what is being billed. But the insurance can't tell that they're on 2 blood thinners now. The insurance can't tell that they've been to 4 doctors. The pharmacist sees all that, but they can't report that anywhere because their systems don't go in like referral. So to answer your question, it would be on preventive dollars. We're preventing adverse outcomes.
Oh, pardon me, Carrie, if I might, Representative Wood. But we're taking it to the same place that I was before. The improving the billable and the process, the billing for pharmacies is to improve outcomes, and it's basically to do preventative.
Mm-hmm.
But nothing within the scope of that activity on a billable hour is going to reduce my billings, other than what you're calling in I don't know whether it's extreme, 5%, 10%, 20% of the cases, we're going to be preventing dire consequences. But I'm not delivering service cheaper, other than at that forward point on preventative. And I think if we are transferring activity from a doctor to a pharmacist, I think the scope of the practice or the price of the service rendered, I'm not arguing whether the service should be compensated. I'm wondering, if we build out the model this way, I'm going to be paying everyone the exact same price for every service rendered. And it's what I find in the problem with, as we run insurance, we have no competition left in the insurance industry in terms of the rendering of service. Everything's everything is bent to preventative outcomes in the future, and my payment plan is flat, and I'm increasing the amount of services I provide, and therefore my premiums are going up. And theoretically, my premiums are going up and preventing catastrophic consequences in the future. I, I'm not thrilled that the model is absolute that way, and that's why that's where I'm wrestling with price of the service rendered and compensation at adequate levels to provide it. So that, I guess, we differ there. Should the pharmacy get compensated for the work they do? Yes. Versus, but if it's the same coding for a doctor and the same price, I'm trying to figure if I'm comfortable with that. But I hear you.
Yeah, and I think you got to think about 2 things on that thought process. I think we are in that spot not because of pharmacists. I think what you're talking about is a very real problem, and I think that's been created by everyone except pharmacists. Would they contribute to that road? Absolutely. But I think other preventive things we've seen, would we rather pay for a flu shot, or would we rather pay for someone to go to the urgent care with the flu? The number one reason a broken hip patient dies is from pneumonia. So would we rather they're having access to physical therapy? And I mean, this is not just pharmacy. I'm just saying a lot of the preventive things that happen are very expensive things. Contraceptive. So the first contraceptive prescribing was given to pharmacists in West Tennessee because they had an opioid problem. And they had a lot of opioid addicted babies being born and going to the NICU. And they were $1 million babies. That year on babies with opioids, they spent $23 million as a part of their Medicaid budget. And so, would you rather pay the pharmacist $13 to prescribe some birth control, or would you rather pay for a NICU baby? And I think there's just lots of examples out there where take pharmacists out of the picture, okay? it's not about being a pharmacist or not. It's more about access to care. We have many different studies that show that a patient goes to the primary care physician on average 3 to 4 times a year. And the data shows they go into a pharmacy 33 times a year. So the access to care is what you're looking at there. It's not about the other pieces. And I get what you're saying. I think that will increase it, but I think tracking those outcomes, we have a real problem in healthcare. No matter what provider you're seeing, I mean, we have a very big problem. And I think access to care is a big piece of that, because anytime you go see someone, you're getting referred to the next specialist and the next specialist. And this doctor can't see this other doctor's MRI, and this doctor can't see the labs for this other doctor. So I think it's a different problem that is a very real problem, but I don't think that pharmacists are the cause of that.
Oh, I'm sorry, I'll leave it at this. I agree. I don't think the pharmacies are cause of this. I think compensating pharmacies for what they do, I'm not objecting. I'm
Sure.
questioning about the levels and the overall cost of the system.
Yeah.
And if there are measurements on the benefits, particularly the Tennessee measure, there's no reason to think about a differential in cost or because of the overwhelming cost, and it's not being delivered by anybody else at that point.
Mhm.
Right? But there's a host of other issues that are done either by the doctor or the pharmacist, and I would prefer to see a little competition on the price basis on some of that, and
That'd be
some
great.
compensation for pharmacists. All right. But thank you.
Yeah.
Thank
Thanks
you,
for your
Madam Chair.
question.
And thank you, Madam Chair, for your patience.
Thank you. It was great feedback. Sam?
Thank you so much. I'm glad we are not debating the value of the clinical services or improvement in outcomes on the patient side. So it's good to hear that everybody agrees on that. So it comes down to economics. And we are definitely not proposing that pharmacy service will be the cheaper alternative to physicians. It's the same service that provide the same outcome. They should be dealt with the same. We really wanted the committee to look at the total cost of care, not at the specific cost of the service. There are many published papers and experience across the country to show that pharmacy engagement in these clinical services decrease the spend on drug itself. So I think Travis talked about side effects and drug interactions and potentially hospitalization. But when we look at the drug profile, on the average, a pharmacist can decrease the medication list by 2 or 3 drugs for every patient. Many patients that get admitted to the hospital start on a drug and continue on the drug for 2 or 3 years. And you ask the patients, why are you on that? They don't know. So we decrease the total cost and total spend on drugs. We also decrease the total cost of care. We can provide that. There are also papers published on decrease unwanted pregnancies when pharmacists engage in birth control. So I think rather than looking at the specific service and the cost of that service, we need as a state and a society to look at the total cost of care. The other thing, in terms of competition, I think the way the competition will be value-based care. And that's when physicians and pharmacists and all healthcare providers should be paid based on outcomes. If we are opening the door, allowing pharmacists to be treated as providers, we'll be able to decrease the total cost of care and improve competition by engaging in this value-based care. We will get paid based on outcomes and not necessarily on services provided. This is where healthcare needs to go, but we need to start somewhere. And what we're looking for is a framework for allowing pharmacists to be treated as providers to get us in that space to show what else we can.
Great. This has been fantastic. Any other questions for Dr. Wolf? Sue Halpin?
Just one. Thank you for your presentation. And just a very quick question. I'm trying to understand what CPESN is. Is it an accountable care organization and a billing intermediary kind of combined? Who you actually contract with? Is it with payers? Is it with provider groups? Is it with employers? If it's not Medicaid and Medicare directly? And then thirdly, do you contract and bill for services today in Connecticut?
I can say yes to everything, right? So CPSN is a clinically integrated network who sets sub-minimal standards so that a pharmacist or a pharmacy has got to prove that they meet those standards to be inside the network. Every single month, we pull their performance metrics to make sure they really are providing these enhanced services. And I am contracted with CPSN USA. So we've got a certain set of standards to be inside the clinically integrated network. Okay. And then each state can have their own chapter as well, and they can set their own specific standards. I would let Ed answer here in a minute if the local chapter is contracted at all, but your questions are all really good. As a part of a network, we like for the state chapter to do the contracts, and that can look a number of different ways. We have value-based care contracts with straight Medicaid. We have value-based care contracts with managed care organizations that are managing Medicaid dollars. We also have got some fee-for-service type contracts with commercial payers. We also have got large, they're a value-based care program, but it's like a per member per month type contract if we meet certain standards. And the payer defines those standards for sure. Ed, do you know if you guys are doing any personal stuff there in Connecticut?
Not at this time, Travis. It's one of the issues was pharmacists being recognized as providers. We've had a lot of, not for lack of trying, but we've had a lot of pushback, not really understanding all the stuff we've been talking about here and how to implement it. So Connecticut does not have a program going. CPSN is a national organization that provides quality standards as it would apply to Connecticut. We do have a chapter in Connecticut. There's about 34 pharmacies in it right now. We probably would have a lot more if we had billable opportunities. So there's pharmacists that are doing things, and the leadership in Connecticut ensures that the pharmacies, so we have our own leaders for the Connecticut chapter, and they ensure that the pharmacies in the network are meeting the quality standards of the national program, plus a few additional standards that we require to be a member in Connecticut.
And value-based care is not something I talked a lot about today, but it's a great option as well because it does not require the pharmacist to be a provider. The pharmacy is the recipient of the dollars, and you can set metrics that might be around medication adherence, gap closure analysis. It doesn't have to be provider type activities, and the value-based care is a great opportunity. In fact, some of our states, they might hold, I know Pennsylvania, I think they have 24 different payer value-based care contracts, and they had all of those before they ever got provider status. Provider status just started this year for them. So it's a great option as well. One of the reasons that the clinically integrated network status is important and why CPSN has kind of become a player in this, there are a lot of federal antitrust laws where you can't share these rules and fees and payments across state lines unless you're a clinically integrated network. And because we are, and we follow all the antitrust guidelines, we're allowed to do that. That's an important piece because, for example, when I work with Blue Cross Blue Shield in Arkansas, it is so easy to work with. They have a manual that says, here's exactly how we're going to credential pharmacists. Here are the exact codes we want you to use, and here's how many dollars we're going to pay you. When I get to Blue Cross Blue Shield in Texas, right down the road from them, they say, pharmacists or providers, bill us. They don't give us the codes. They don't give us the dollar amounts. They don't tell us how to register a pharmacist as a provider. They just say, you're a provider, bill us. Well, how much should we bill? And what are the codes? And I will tell you, pharmacist personality, if they don't know that they're doing it right, if they don't know the rules, they just won't do it. They just shut down. And so they can't talk across state lines. So I can say, hey, Denise, would you talk to Monica? Because Monica's got a great plan and we've got great outcomes. We've got great data. And Monica will say, even though we're both Blue Cross Blue Shield, I can't share my data across state lines. However, on CPSN side, because we follow the antitrust and we meet the qualifications for a clinically integrated network, I can take that data and I can show both payers, here's what we're doing in Arkansas. Would you be willing to look at that in Texas? And then they can see the ideas and idea sharing and get better patient care.
Great. Any other questions? Great. This was fantastic. Dr. Wolf, thank you for joining us today. Troy, thank you for your presentation as well. Why don't we talk about deliverables for next meeting? Are we at a point where we can start to take some time over the next few weeks to construct what we'd like to see regarding changes in statute or scope or all that good stuff and bring it to the next meeting? I'd like it to get into Ally's hands prior where she can circulate it to everyone, and then we can just have a roundtable discussion on what everyone's presenting and start to hone in on what we'd like to present to the legislature. Does that sound good? Okay, great. Let's look at our calendars for Sue Halpin.
Just a bit of comment on what we heard and what I would hope to see in our coming discussion. I am still struggling putting a mandate aside, which I couldn't support on behalf of the carriers. I understand mandating reimbursement for services. I understand all of that. I am still not clear after all these discussions on what is preventing this kind of compensation and reimbursement on a voluntary basis now. Is it licensure? Is it scope of services? I imagine that many of this, I don't understand the scope of service for the pharmacist today, how much of their licensure is inclusive of many of the things that were discussed today versus what would be expanded. I completely understand that, there's a conversation about, an increased level of consultation that may be happening related to the expanded scope of service. But I'm just still not clear why a organization in Connecticut, CPESN, is prevented today from entering voluntarily into an agreement with any service. I do understand, and I think it's really important conversation as we go. And I found it really important that I didn't know before that you cannot spend federal dollars on reimbursement to a pharmacist directly, if I understood what was being discussed today. So that's really huge. And then we talk about, okay, so now the pharmacy is a provider. So how does that work under the definition of healthcare provider in Connecticut? And does it have to be under a collaborative practice agreement like happens for perhaps other entities? So I don't think it's as simple as we want to discuss or want it to be. I understand what other states have done, and I'm putting that over here because that is a mandate, and that's a mandate for services and reimbursement. The question is, are we expanding the scope of service? If we're proposing to expand it, what does it include in the future that it doesn't include today? And then what's the statutory framework that is preventing these kinds of organizations from entering into voluntary agreements today?
Anyone like to comment on that? Travis, do you have any feedback? Anyone?
I have all kinds of feedback, but I'll try to be brief. So the scope that is there and what is trained, basically the training that is occurring in pharmacy school is misaligned with the scope that's defined in old statutes. So the ability to do some of these things are normal workflow in pharmacy. The issue that we have, there is an organization called the National Committee for Quality Assurance, NCQA. They are an independent nonprofit organization, and they have been given the authority to improve healthcare quality through basically the administration of what they call evidence-based standards and measures. So they are the ones, and why they're important is they are the ones that establish the set of standards that currently serve as a guideline for healthcare payers to credential a provider. So because CMS has not given the ability for a pharmacist to be a federally qualified healthcare provider, then there is no set standard by the NCQA on how to credential a pharmacist. So even though the activities we're asking to be paid for, there's no way to register them in the system because the payer themselves does not have that NCQA list of requirements. The payer has to account for where they spend their dollars. So they cannot pay it to a non-qualified provider. Just like if you, I don't know your background, are you a physician by chance?
I
No,
am
she
not.
is not.
Okay, so if you went and said, I'm a physician and I treated a patient, I want to be paid, that would be total fraud, right? So if they try to pay a pharmacist, but they can't be licensed and credentialed, then that would be total fraud, even though we're capable and trained. So that we need that ability from the states to define how do we decide who is a qualified pharmacist that can provide this, because it's not on that list. And it's done a lot of weird ways. I mean, in Oklahoma, Medicare themselves says that a pharmacist can be a diabetes educator under diabetes self-managed education. But because they're not on that NCQA list, here's the actual process to credential with the Medicaid in Oklahoma. You register as a certified diabetes educator, even though you're not one. The actual process in the manual says you apply and you get denied because you're not one. And then you reply to that denial with your active pharmacist license and your diabetes self-management education accreditation, and they add you to the Medicaid as a provider labeled as an other health certified somebody. It literally says somebody, because they can't put a pharmacist in that blank. So the NCQA, they're the ones that tell all the payers, here's the things you need to make sure they're a qualified provider. But we're not on that list. So the state's going to define what that list is.
And have there been any conversations with NCQA?
Well, they can't do it until CMS changes their statutes, and you'll have to go through the CMS budget.
Julian?
And just to add a little bit, in regards to the collaborative practice agreement, we've had it in the state now for approximately 4 years. And the uptake on it has been very limited. Obviously, we understand pharmacists are a backbone of health systems, and I think Sam can definitely add to that. The reason why that collaborative practice agreement hasn't taken off, there's no reimbursement. So either the hospital system will have to put that cost up front and take it from themselves. But from a retail standpoint, there's no pharmacies really participating because there's no way for us to get paid for that service. One of the programs that I was working on was for high-risk population with blood pressure testing with one of the health systems in the state. And these are patients that don't have the accessibility to reach their provider. They are the ones that are impacting the star ratings for the hospital system. They are impacting the quality of care that's being provided. And the only way to be able to progress with that is if the hospital system would pay a fee for getting and reporting back that blood pressure testing during a visit. And as we know, patients do visit the pharmacy approximately 13, 14 times a year. We could be that primary standpoint and close that gap. And we all know in the next 10 years, I think there's numbers anywhere from like 20 to 40,000 primary care providers that will be short. And I think from a cost standpoint, which also came up, when a patient comes to us, the only recommendation that we do give outside of what we can, we're like, okay, you got to go see your primary care, you got to go to the ER, or you got to go to urgent care, when we can close the gap in a lot of those. And if I think of the times that I, as either a parent or as a pharmacist, have tried to either get my kids to a primary care physician, has been impossible. Get my parents to a primary care physician has been impossible. But that referral time frame of, hey, you can initiate therapy, I can do a flu test, I can start you on something, and then I refer you to your provider. It frees up the time for your providers to also provide better care to more complex patients. And I think that's where initially when we started, the DPH definitions of providers, pharmacists missing from there is definitely a gap. And I think from DCP's perspective, managing the credentials and the licensing, if pharmacists that are licensed under 400J were included in that piece, it would definitely open up the opportunity for us to provide services and get reimbursed for services.
Sam?
Real quick in 10 seconds, because I didn't hear the answer to the first part of the question. We are not proposing to change the scope of pharmacy license or practice. We just want to create a framework for what we have today. So it's not something what we're trying to change today.
In the state right now, we do have some pharmacies that are doing collaborative practice agreements for long-acting antipsychotics, for instance, but they're not getting reimbursed for it. So that is being done. There's a protocol that's set with a physician, and they're able to make changes in therapy and suggestions to therapy as well.
All right. Really great discussion today. So looking at your calendars, how is Wednesday, October 29th, 11 a.m.? Sounds good. All right. So that will be the date and time of our next meeting. Please send recommendations to Ally on what you are proposing. And if you need assistance from us, whether through our research department or anything else, please don't hesitate to reach out and we can get more information as well. And we also had sent a lot of materials early on. If anyone needs us to recirculate those, always feel free to reach out. Any other comments or questions? Seeing none, we are adjourned. Thank you, everyone.